People talk about sugar and weight in diabetes, but an overlooked lever is iron. Iron is essential, yet when body iron stores stay high for years, it acts like rust, raising oxidative stress and making metabolism work harder. This video does not demonize iron. Iron deficiency is still common. We focus on long-term high iron stores, the evidence, mechanisms, and practical plate and lifestyle tweaks. Why does high iron cause trouble? Reactive iron catalyzes free radical formation, like sparks flying inside the body. These oxidize proteins, lipids, and DNA, driving oxidative stress. It is not an overnight disaster. It builds with dose, time, individual differences, and diet pattern. The earlier you notice it, the easier it is to correct gently. Pancreatic beta cells secrete insulin, but have weak antioxidant buffering, so the sparks repeatedly scar them, making secretions sluggish and variable. Meanwhile, muscle and liver under oxidative stress respond less to insulin, like the key is fine, but the lock is rusty. When secretion and use both falter, glucose rises more easily. Population evidence. A 2004 JAMA cohort followed 32,800 initially healthy women for about 10 years. Higher ferritin, an indicator of iron stores, was associated with higher future risk of type 2 diabetes. The link persisted after adjusting for weight, diet, activity, and other factors. The sTfR to ferritin ratio pointed in the same direction. Ferritin is not a perfect iron ruler. It's influenced by inflammation. Interpretation should combine inflammation markers and other iron indices. Think puzzle pieces, not a single cutoff. For most people, the message is not iron causes disease, but that long-term high stores tilt the metabolic background in an unfavorable direction. Stay rational. Avoid extremes. Mechanisms. A 2023 annual review of physiology notes that higher tissue iron can lower insulin secretion, reduce insulin sensitivity in peripheral tissues, and increase hepatic glucose output. Iron also acts like a metabolic conductor, shaping fuel selection, adipocyte phenotype, and cell signaling. Hepcidin is the gatekeeper hormone. With high stores or inflammation, hepcidin rises, reducing intestinal absorption and iron release. With deficiency or high blood building needs, hepcidin falls, increasing absorption and mobilization. That is why the same meal is absorbed differently in different states. Interpreting common labs, ferritin reflects stores. Transfer and saturation, TSAT, reflects the share of circulating iron that is available. Soluble transferrin receptor, sTfR, rises in deficiency. Read these together with CRP or other inflammation markers to approach the true iron status. Genetics and causality clues. Some variants align with higher iron load and with adverse glycemic traits. In diet studies, higher heme iron intake, mainly from red meat and organs, tracks with worse glucose-related markers. These are not prescriptions, but consistent pieces in the evidence puzzle. Dietary iron. Heme iron from red meat organs is readily absorbed. Non-heme iron from beans, whole grains, and plants varies with the meal environment. If the plate is dominated by red processed meat and short on whole grains, legumes, and vegetables, stores tend to creep up. Nudging towards seafood, legumes, whole grains, and vegetables can dial them down. Absorption modulators. Polyphenols in tea, coffee, cocoa, and some spices gently reduce non-heme iron absorption. Vitamin C increases it. For people with deficiency, vitamin C at meals helps. For those with high stores and clinician approval, polyphenols and high-fiber vegetables can act as a buffer. Personalization first. Safety boundaries. Pregnant people, menstruating teens and women, and those on poorly planned vegetarian diets are prone to deficiency. Do not copy lower iron tactics. Fatigue or dizziness does not equal deficiency. Test first. Supplements. Stopping supplements, blood donation, or medications must be decided with a clinician. Education is not a prescription. Plate strategy. Move red, processed meat from frequent headliner to occasional side, especially in those easy weekday meals. If you keep red meat, shrink the portion and pair it with half a plate of vegetables and whole grains. Plate strategy. Raise the share of seafood and poultry, salmon, mussels, oysters, shrimp, chicken breast. Seafood is generally more metabolism friendly. Shellfish also bring zinc and omega-3s. Plate strategy. Include beans or soy foods daily or on alternate days. Chickpeas, lentils, black beans, tofu, tempeh, to replace part of the red meat. Swap refined staples for buckwheat, oats, barley, and brown rice. Lifestyle. A 10 to 15-minute walk after meals can blunt glucose peaks. Strength plus cardio makes muscle more hungry for glucose. Sleep and stress management shift hormones from tense to adaptive. Iron is one puzzle piece. Rhythm and consistency are the frame. Iron-manganese balance. Manganese supports carbohydrate metabolism enzymes and is typical in buckwheat, oats, barley, and chickpeas. Long-term high red meat plus low whole grains tilts toward high iron, low manganese. Fix it by making half the staples whole grains and adding a daily serving of legumes or soy, raising manganese, fiber, and polyphenols together. Zinc and insulin. In beta cells, insulin is stored as zinc-stabilized hexamers. Transporters like ZNT8 help package and release. Prefer food first. Oysters and mussels are rich in zinc. Pumpkin seeds, sesame, and cashews can support. Avoid long-term high-dose zinc to prevent copper disruption. Copper-zinc balance. Minerals are about balance. Red meat often brings more copper, while zinc is key for insulin granules. Replacing part of the red meat with seafood, legumes, and nuts moves the combo back toward the middle. Principles: food first, not excessive. Avoid single nutrient megadoses. Selenium and thyroid. Thyroid hormones shape basal metabolic rate and glucose lipid metabolism. Selenium supports antioxidant enzymes and thyroid turnover. Sources include Brazil nuts and seafood. Use small food-first amounts. Gut microbiome. Diverse fibers and polyphenols feed sTfA-producing microbes, linked to better insulin sensitivity and lower low-grade inflammation. Practice. Rotate legumes with the gluten-rich oats, barley, prebiotic alliums, leafy greens, berries, and tea coffee polyphenols. Push sugary drinks and ultra-processed snacks toward occasional. Bile acids and metabolism. Whole grains and polyphenols can shape the bile acid pool and receptor signaling, e.g. FXDXR-TGR5, touching energy metabolism. You don't need every detail. Remember the principles: variety, fiber, polyphenols, less processing. Circadian rhythm. Insulin sensitivity, hepatic glucose output, gastric emptying, and absorption follow a schedule. Put higher carb meals in daytime and around activity. Make late-night snacking smaller or skip it. Regular routines beat scattered fixes. Exercise prescription. Do 2-3 strength sessions weekly to grow muscle and upgrade glucose use. Aim for 150 to 300 minutes of moderate cardio per week. If you sit more than 60 to 90 minutes, stand and move for 2 to 3 minutes. Small, frequent actions beat occasional heroics. Sleep and stress. Poor sleep and chronic stress raise glucose via cortisol and sympathetic drive and disrupt appetite signals. Set a digital curfew, warm evening light, and consistent schedules. High-return investments in metabolism. Special group. Women. Heavy menstrual bleeding often means borderline deficiency. After menopause, stores may rise. The paths differ. First group needs guided replenishment. The latter can consider gentle structure tweaks if stores are high. Special group. Men. Family history. Men are less often deficient. Watch for silent high stores. If family members have iron overload or high ferritin, discuss labs and interpretation with a clinician. Vegetarians, vegans. With good structure, you can have enough iron without excess. Pair non-heme iron with vitamin C. Rotate legumes, whole grains, nuts, seeds, and deep green vegetables. Medications and supplements. PPIs may affect iron absorption. High-dose zinc can suppress copper. Calcium and iron interfere when taken together. Confirm timing and need with your clinician. Avoid making your own treatments clash. Blood donation or venesection. Consider only when a clinician confirms you are suitable and it is necessary, especially after ruling out anemia, occult bleeding, and underlying disease. Personalization first. Don't treat online anecdotes as prescriptions. Weekly template. 2 seafood meals with half-plate vegetables plus brown rice, barley, 2 legume mains with buckwheat, 2 poultry meals, 1 small red meat meal kept for enjoyment, a small handful of nuts daily, rotate spices like cloves, cinnamon, and turmeric, walk 10-15 minutes after each meal. Shopping list. Whole grains, buckwheat, oats, barley, brown rice, 4 bags, legumes of 4, shellfish, fish 3 portions, poultry as 2, red meat 1, dark leafy and cruciferous vegetables for 7 days, berries, citrus 4, pumpkin seeds, sesame, 1 to 2 bags, tea, coffee, plenty of herbs and acidic flavor boosters. Cooking and plating. Less charring. Use low-temperature simmering, steaming, or braising. Plate half vegetables first, then protein and grains. Use acids, lemon, tomato, vinegar, and herbs as free flavor. Prep ingredients before heat to avoid last-minute extra oil, salt, and meat. Beverages. Water and unsweetened tea, coffee as the base. If your clinician agrees with gently lowering iron, pair tea coffee with grain legume meals. If you are at risk of deficiency, think the other way. Combine iron-rich foods with vitamin C-rich produce. Eating out and emergencies. Prioritize seafood or poultry plus 2 vegetables and a whole grain. Save fried foods, heavy sauces, sugary drinks, and ultra-processed snacks for occasional, quick options. Plain yogurt with nuts, whole grain crackers with hummus, unsweetened latte. Progress checks every 8 to 12 weeks. Review meal frequency, red meat counts, vegetable volume, whole grain, legume servings, exercise, and sleep. Weight, waist, and fitness are visible signals. Fasting post-meal glucose and clinician-ordered labs are the inside camera. When progress stalls, first review sleep, stress, and fragmented activity. Then look for the return of sugary drinks, snacks, and weekend exposures. Push the smallest actionable change back into place, not more anxiety. Myths and truths. Cast iron pans cause overload. Typical cooking transfer is limited. Acidic long braises are higher. The overall diet pattern matters more. Cutting sugar is enough? Not enough. Iron status, microbiome, sleep, and exercise act together. Use chelation drugs on your own? No, requires specialist evaluation. Recap. Sugar still matters, but iron status is a second overlooked lever. Lower red processed meat a bit, raise seafood, legumes, whole grains, and vegetables. Use spices and acids to make healthy choices tasty. Walk after meals to smooth glucose peaks. Action and invitation. Discuss testing and individualized interpretation with your clinician. Share this video with someone who may need it. Tell us in the comments what you changed on your plate and where it was hard. Next episode, reading labs, when to recheck, and how to link them with weight and glucose. Education only, not medical advice.